Insulin, that is a very scary word for many people. We don't want that needle, that injection, and but insulin is life saving, and so we need to. Where does it apply? We have Adam, who's really working hard to actually put your diabetes into remission. I'll remind you, if you're a type 2 diabetic for less than 5 years, if you lose 20 to 30 pounds, you have a 70% chance you can put your diabetes into remission if you're not taking insulin therapy. And then we have Judy and Bo. These are two fantastic ladies that probably have a lot more experience than the whole world on how to manage diabetes. They've been around for a long time, and they come to our clinic, and they're wonderful ladies. And they're going to really spend a little time saying, you know what, insulin is not such a bad drug when necessary. Adam, take it away.
Sure. Thank you so much for that introduction, Dr. Curnew. That sets it up pretty well. So we're going to be talking about insulin, the scary stuff about it, just the basics, what you need to know, introducing you a little bit to it. Even if you're not on insulin, it might be educational and helpful. So yeah, insulin. We're going to talk a little bit about diabetes intermission. We're going to have a Q&A section as well for you to get, to go back and forth. And then the action plan. I like to always end with an action plan. Just to, it's one thing to know the theory and the education, it's nice, but transitioning that into action is really important. So I'll pass it on to Bo here, and she could talk to us a little bit about insulin.
Great. So yeah, thanks, Adam, and thanks, Dr. Curnew, and thanks, Judy, for joining too and helping out. And it's absolutely right. When we started talking about this, the issue always is the fear and the concern that people have with regards to insulin. And so we really thought that this evening, what we'd like to do is sort of reduce that fear, make you feel a little bit more comfortable. Right off the bat, just thinking about what is insulin. Insulin is a hormone that the body naturally produces. So when you have diabetes and you don't have enough, it's a very safe approach to managing your diabetes. We know that, the doctor's ordering the insulin. The doctor's ordering the insulin because what you're currently doing in terms of your self-management of your diabetes, your medications, your meal planning, your exercise, your stress management, those things all together are not putting your blood sugar at the target where you and the doctor want it to be. So when we're looking at changing the medication, if with the pills are expecting or encouraging your body to have a response. Some of them get your pancreas to make more insulin. Some of them get the insulin to work better. Some of them get you to pee out more sugar. And if the pills on their own are not getting the blood sugar in control, there's a limit to how much of those medications you can take. There's a maximum. And it's not that they'd be dangerous if you took any more. It's that they're not going to do any more for you because it's expecting your body to respond in a certain way. And at that point, that's when the doctor's probably going to talk to you about insulin. And insulin is very safe. And we always introduce insulin in a very conservative way. And by that, I mean, a very slow, you would start with one injection a day. If you have type 2 diabetes, it'd be a slow, long acting insulin. And it would be in addition to what you're already doing. A lot of times people ask that too. Well, if I'm going to go on insulin, then maybe the rest of my medication is going to be stopped. And so remember, if you have type 2 diabetes, you still need those pills to help the insulin work better, even if you're taking insulin injections. And so insulin is added to your arsenal, and it's something that we use every day in our practice, right, Judy?
Absolutely, absolutely.
Yeah. You can go to the next slide, Adam. And so the next question is, well, what kind of insulin? How much am I going to take? When am I going to take it? And what we actually do is we look and we see, well, what would a healthy pancreas do? And if you look at this graph, you can see that if a person has diabetes and they have a meal or they have a carbohydrate load, if you're looking at this graph in terms of where does it go? And so when it's flat, that means the blood sugar's under control or at target. But when it peaks up, that's in response to carbohydrate intake. And so that's the response that the body's going to have when it digests the carbohydrate. the way that we're going to counteract that response is to match that trend with an insulin that's going to do the same thing. And so the way that we manage that is with slow acting insulin that will keep that background balance or that foundation, and then some fast acting insulin that would work for a short amount of time and really quickly to target those times after a meal. Sorry, Adam, I know you went ahead. You can go ahead now.
Well, actually, just stay at that.
Oh,
Go
yeah.
back at that slide. So one of the things is you can see that insulin is a response to carbohydrate, to sugar intake. So if you have breakfast, lunch, dinner, snacks, your sugar goes up, and then you need insulin to bring that down. Now it's kind of interesting when I remember when Bo first started the clinic a number of years ago. Is when do you give diabetes medications? Well, you want to sort of try to mimic as much as you can what Mother Nature does, and so it's interesting is as the day goes on, your resistance to insulin changes as well. So there's two parts of diabetes you have to remember: is that you need insulin to get sugar into your cells, and sometimes your body in type 1 diabetes, you don't have enough insulin, so you have to give insulin. In type 2 diabetes, people have a problem with your body becoming resistant to its own insulin, and over time your pancreas will unfortunately die. And every type 2 diabetic, if you live long enough, your pancreas will run out of insulin. So what you want to do is protect your pancreas. And what I learned initially was, I didn't do this right, is that if you're taking oral pills for your diabetes, you need to take them in the morning time, not at nighttime. And that's something to think about, is that, is that at nighttime, if you take your diabetes medications at nighttime, you can get too low at nighttime, for instance, at certain medications. So you have to be smart about what you're doing and try to mimic Mother Nature too as well. So interesting about that. Go ahead.
Okay. So then people are always concerned about, well, the big thing with insulin is it's a needle. It means I have to take a needle. And where am I going to take this needle? And how many times am I going to have to take the injection? So let's start with how we're going to do it. So it's an injection. It goes into the abdomen. Now, the reason for that is, there's two reasons for that. One reason is that the pancreas is located midline in the body. So it makes sense that's a good place for the body to receive the insulin. But the other reason is that most of us, unless we're doing abdominal crunches and sit-ups, we don't use those abdominal muscles. So when we looked at that graph and we've seen how the blood sugar was responding, we want the insulin to be absorbed as consistently as possible. We'll talk in a few minutes about how the different types of insulin are absorbed and how they work. But if, for example, you took an insulin injection in a leg or an arm, and you were using the muscle even to brush your teeth, eat your meal, brush your hair, make your bed, that type of activity in those muscles could change the way that your body absorbs the insulin. And so it's a pretty safe bet that when your physician or your educator is looking at your blood sugars, if you're taking your insulin in the abdomen, that it's going to give you the most consistent absorption. In terms of different types of insulin, as I said, we want a background of insulin. So we'll talk in a few minutes about some slow, long-acting insulins that you'll typically take once a day, sometimes twice a day, just to kind of give you that foundation of insulin so that you've always got some insulin in your system. And then the other kind of insulin that you take prior to a meal so that it works faster for a shorter amount of time, because that's the way the body digests carbohydrate. And so is this a good time, Adam, for me to maybe show the insulin pen? And
Yeah, if you'd like to, sure.
Okay, so here's an example of an insulin pen. And I just want to show you, let's see if I can do this. If I was down in my abdomen area, so I've got my insulin pen. Is this okay, Adam, that the way is it showing all right?
You can see perfect. That's awesome.
Okay.
Thank you, Bill.
And there's a pen tip. You just peel back the paper, because of course it's a sterile pen tip. And I want to show you how short it is. Take these two caps off, and that's the length of the needle. So when people are afraid, it's only a 4 millimeter needle. It's designed just to go under the skin. And so then the way that the pen delivers the insulin, you turn the dial and it'll deliver some insulin through the end of the needle. The first thing you do is you prime that needle. That's going to make sure that you've got insulin all the way to the end of the needle. And then let's say, for example, the doctor said, well, I want you to take 10 units of insulin. You would turn the dial to 10. And then getting back to my injection technique, I'm going to go straight in. No pinching, none of that. You're just going to go straight in. I'm going to keep that dial so that it's facing up so I can see. I'm going to push the end of the pen. The pen will deliver the insulin. The first thing I notice is I can't push anymore. The second thing I notice is that there's a 0 in the window, and that tells me I got all my insulin. Now, because the diameter of the the insulin cartridge is quite large compared to that little hole at the end of the needle, there's a little bit of back pressure. So I'm just going to count to 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And then I'm going to take the needle out, take the larger cap, put that on, and take that off. And then I'm good until the next time I take my injection. So you can see that this can be very portable. If you're out at a restaurant, it's very easy to take your insulin because we did talk about taking it before meals. And so some people may be concerned about that.
So, but just a question. So,
Yeah.
do I need to sort of do I have to get wipes or alcohol in the area, or what do I have to do before?
Yeah, that's a
I use
good
it?
question. So a lot of times people are started on insulin in the hospital, and the hospital is a really dirty environment, and the nurses are using alcohol swabs to clean everything. But we've actually found through time that when people are in their own environment, Adam, even when they're out in the community, even with this whole COVID thing, alcohol actually, for it to actually clean anything, they've got to vigorously rub it for 30 to 60 seconds, let it air dry. And nobody does that. You saw how quickly a person would be able to take their insulin. So they're probably not going to do that. And in addition to that, alcohol actually dries out the skin. And over time, it can dry the skin, and the skin itself is a protective barrier. So with that little tiny fine needle, it can actually go in, deliver the insulin, take the needle out, and the skin just closes up again. So the risk of infection is actually greater if we use alcohol and we crack open the skin. So that was a good question. I don't know if you have anything to add to that, Judy.
The only thing that I would add is giving it in the abdomen, yes, but just making sure that you give it in a different spot each time. That's
yeah,
probably
good point.
rotating the
Yes.
sites.
Thank you
I
for
mean,
that.
you're going to be on it for a long time, and I think the other thing too, when we talk about insulin, people think of it as a punishment, and it's not a punishment. It's an addition, another tool in the toolbox. So, as you said, you're on your medication, you've done all you can, it's not going to do anything more. So it's just to keep you living a long and healthy life, not because you failed at anything.
Yeah, good.
Now, you said something about priming. What is priming? What does that mean?
So that means, Dr. Curnew, I'm going to be putting a new pen tip, a new needle on every time. So each time there's a pocket of air in that needle. The other, so by doing a 2-unit prime, I'm getting insulin all the way to the end of the needle. The other thing is, because the needles are so fine, and because the system involves, I've got to puncture my insulin, I also want to actually make sure that my system is patent. In other words, I'm going to get my injection. So by doing that 2-unit prime, I can see that insulin come out, and I know that when I deliver my dose, I'm going to get it all. It's important actually, because if people aren't doing that, particularly when they're opening a new pen or putting a new cartridge in, they could actually be getting less insulin than what they're supposed to get.
Thank you.
You're welcome. So here again is a different way to think about how the meal is being absorbed. What does that do to our blood sugar, and then the different types of insulin? do the insulins come onto this slide, Adam, if we click it again?
I believe so. Oh, there we go.
Oh, okay, no, I guess they don't.
But are you looking for this?
I thought, see how on that slide at the bottom, it talks about different types of insulin?
Yes.
I thought maybe the different colors would come up.
Ooh, okay.
But that's okay. So we talked before about the different types of insulin. So if you look at this, what you're seeing is the rise in blood sugar related to the meal. To match up with that there would be a fast acting insulin at that first meal, second meal, and third meal, and then the longer acting insulin at night and or in the morning. Sometimes people need to take it twice a day. Depends on the type of insulin and how you're doing with your diabetes.
So the body has one type of insulin. How come you have so many different types of insulin?
Well, because we haven't been able to exactly copy what the body does, Dr. Curnew, unfortunately. But thank goodness we've got the technology to be able to make these different types of insulin so that we can closer accomplish what the healthy pancreas does.
So it's kind of interesting is that you need some background insulin to maintain health.
Yes.
And if you have no insulin whatsoever, you go to something called diabetic ketoacidosis, which is an acid state which is really unhealthy, and it can lead to hospitalization or potentially deaths. And that's what type 1 diabetics get because you don't have insulin, you're in trouble. But most people who have type 2 diabetes have some degree of insulin production, so it makes that much less common. And then you need to respond to that. So the Mother Nature has done a wonderful job. And so my plea to everybody is that since I started clinical practice, diabetes has already tripled. It's becoming the new biggest problem at this stage. So protect your pancreas by doing all the other things that Adam and Nurme and other people talk about, and Judy and Bo, is that, from keeping your weight down, exercise, but, the pancreas will wear out in some of us. So, and I'll show you a good example of a history of a diabetic, my family history at the end, and just showing you what can happen if you're not careful. And so it's interesting. So you need some basic background insulin therapy to keep yourself, healthy in a proper state. But you also need, these boluses of insulin to help get the sugar into the cells with meals and things of that nature as well. And you can imagine if you're sick, you're dehydrated, your state of insulin requirements can change. So it's not just a one-to-one relationship. There's so many factors, and you're right, Mother Nature has done a great job. So we're never as good as Mother Nature.
Mm-hmm. I'm just going to add to that, Dr. Curnew, and sometimes people get very nervous about the whole idea of taking their long-acting insulin at bedtime. So I just want to take a minute to address that. We know with people who have type 2 diabetes, with the resistance to insulin and the other component with the liver being over generous, adding glucose to the blood, and that happens overnight. So often we hear from people that, I don't understand why my blood sugar is 14 when I wake up in the morning, but it was 7 when I went to bed. And they think that we're going to be accusing them going and raiding the fridge. So that's that whole phenomenon where overnight, when the body's rejuvenating and it's left to its own devices without any carbohydrate or any food intake, that the liver dumping glucose into the blood and then the pancreas not being able to match up with that will lead to that phenomenon of them having a higher sugar in the morning. And so the way that we counteract that is to actually give that long-acting insulin at bedtime. And that's often the first sort of one injection a day that we often suggest for people. And that's the reason we do it, because we're targeting that problem. And the benefit of that is if you wake up and you start your day with a better blood sugar, sometimes you can go with your pills during the day to manage with your meal planning and your exercise. If you start off in a better place, you're better able to do that.
It sounds to me there's a lot of experimenting going on. It's not a one size fits most.
That's right. That's why blood sugar monitoring is important, Adam.
Yeah, which we'll talk about in a bit.
Okay, and this, so we'll look in a minute at a graph of how the different insulins work, but basically we said there's different types of insulin. So we've got some rapid acting insulins. When we talk about onset, it means how long does it take for the insulin to get working? That gives you an indication of, you know, when you have to take your insulin. So for example, if this first class, this first group of rapid insulins, if they start to work in 10 to 15 minutes, then that means if we want to cover the carbohydrate at the meal, we're going to tell people to take them about 15 minutes before the meal. They peak, most of them peak 1 to 2 hours after they're taken, and that's a really good match with carbohydrate intake. And they hang around for about 3 to 5 hours in the body. The previous to those rapid acting insulins, we had the short acting insulins, and you can see that they hang around for a little bit longer. So we don't tend to use those routinely with people. And then at the bottom, we've got those longer acting insulins. And again, the older ones are the NPH, the intermediate ones. But we've since got these really good long acting insulins that really can give a foundation for 24 hours, so that if we're intending that that insulin is going to work for the whole day and give them that foundation, they're going to wake up with a good blood sugar and they're going to be able to maintain that between meals. These insulins on the bottom are a good choice. And it's almost like a buffet out there. There's all kinds of different insulins. And again, the key thing is visualizing the treatment plan and looking at the blood sugars, what's going to work best for a person. Some people are better or okay with taking multiple injections. Other people want a more simplified treatment plan. The key thing is we look at what is the problem area with the blood sugar and match that up with whatever type of insulin is going to do the job for them.
So it's kind of interesting because there's new and older insulins, there's different pricing of insulins too as well. So don't be afraid to discuss price of insulins and things of that nature too as well. Also, at one time there was beef or pork insulin. Does that still exist at all?
No.
No, again, you know, it was the best thing we had at the time, but the body over time, when our people, we were saying, people, Judy was saying, these people are taking insulin for an extended time period. And over time, the body was recognizing that it's something foreign to the body and was starting, you know, to react. And so they'd have to take more and more of those types of insulin, and the effectiveness was decreased. So these insulins that we have now are, you know, they are closer in the molecular structure to the human insulin molecule. So a lot better tolerated. Yeah, they work a lot more efficiently in the body.
I noticed some say clear or cloudy. Does that mean anything?
Yeah, I mean, the reason that's important, Dr. Curnew, is if people take those types of insulin, anytime there's a cloudy type of insulin, when they administer the insulin, if we can go back to my pen, they'd have to mix it a little bit. Either, you know, it's like it becomes like an oil and vinegar type of a mixture, and it'll settle out over time. If the pen is laying there, it'll settle out. And so in order to get a consistent medication, they need to just mix it up a little bit. That was a good question, actually. We don't tend to use too much of those anymore, but still good to be aware of.
Now, storing them, you have to store them in the fridge. Can you put in your back pocket, your purse? What happens if it gets in the warm car? What happens to insulin?
Yeah, so insulin is good at room temperature for 30 days. So the warm car, no. And you're right. I'm sure Judy can attest to the fact that I've had construction workers in the heat of the summer and they wonder why their blood sugar went up even though they took their insulin. And it's related to the storage of the insulin. So good at room temperature for 30 days. If you're when you go and you get your box of insulin, the extra pens go in the butter keeper in the fridge door. You don't want them to go to the back of the fridge and get frozen. Yeah, all of that can affect the effectiveness of the insulin.
No, I
Seems
know.
like
Nurme has a I think.
Oh,
Nurme
yeah,
has-
sorry, Nurme, sorry, there, Nurme, go ahead.
I've seen a lot of patients who say, that sometimes they need to change the amount of insulin that they're going to take, especially for the rapid acting insulin analogs. They change the amount of units that they need to take based on the day. Would you recommend this? How would you recommend patients, when how would you know that patients can change their rapid acting units, and how would you know that patients should be feeling comfortable when changing them? Is there
Yeah.
some sort of limit? Is it just experience?
So I think what we have to keep in mind is think back to what's the purpose of the rapid acting insulin. It's to cover the carbohydrate. And so there's a lot of work to be done and a lot of learning on the part of the patient, because they need to learn how to count their carbohydrates, and they need to work with their dietitian. And the dietitian then can actually help them to develop or to determine what's called a factor. And so they would use that to determine how much of that rapid insulin that they're going to take. So the best thing with diabetes is consistency. However, if we're changing the amount of carbohydrate that we're eating, then it makes sense that we need to change the rapid insulin, but it has to be done in a methodical way. I hope I answered your question. Maybe you can jump in, Judy.
No, I think you did a good job. I mean, it's difficult for type 2s because, they're on orals. You can't, and with most of them don't take rapid insulin, but anyone that is really needs to sit down with the dietitian and figure out how many units of insulin they need per carbohydrate. So that, like with feasts that are coming up, or if they're doing activity or eating a little bit less or eating a little bit more, to adjust it. So it's not, it's there's a science to it, there's a calculation to it, but it really is a discussion between, the provider and the patient to sort of figure out how much they actually need.
Yeah.
But as you say, consistency is the key.
Yeah. And then I would just add two other things. One thing is, when Judy mentioned the exercise, sometimes people are concerned, well, once I start taking insulin, I'm going to have a hard time losing weight. But if they plan that activity so that it's within that time action profile of that rapid insulin, they can actually take less insulin. So they could eat a certain amount, plan that activity during that action time of that insulin, like after the meal, and take less insulin. And so that way they're replacing that insulin with that activity, which will actually help reduce the risk of low blood sugars related to the activity and help them with weight loss. I had another comment and I just forgot what it was going to be.
So what you're thinking about that, here's a question for you, Judy. Some people want to take their basal insulin in the morning time. When should someone take their basal insulin in the morning time versus nighttime with these long-acting ultra insulins?
So with the long-acting insulins that we have now, with the exception of the NPH, they have such a long profile that some people are able to take their insulin in the morning if that's more convenient, or in the evening. So, and one of the indicators, of course, is looking at their blood sugars. So if they're going low overnight a fair bit, sometimes it's better for them to take that insulin in the morning. It will work better for them, and it's long enough acting that it will still have effect on the glucose that's being spilled by the liver overnight. So again, it's very individualized. The only one that's tricky to take in the morning is the NPH, because it has a shorter profile. It's only there for about 12 hours at the most, and does its best work about 4 to 6 hours after it's been injected. And that's the cloudy insulin.
Yeah, you also said that it's kind of interesting. I remember when I first started, we say you took 2/3 of your insulin at morning, 1/3 at nighttime, and the body does funny things. Is that you can actually make your insulin work better by obviously watching how much carbohydrate and simple versus complex carbohydrate, how much you weigh, how much you exercise. And so, but usually when you're a type 2 diabetic, it's not that complicated. Is that you have production of insulin. You often just need a little boost. So we often start at 10 units of a long-acting insulin at bedtime. And it's remarkable how that really, that little bit of extra insulin makes a huge difference in some people. And it's not a huge amount. You're very low chance of too low blood sugar. You mentioned the word hypoglycemia. So if you could just define to people, what is it too low? What's the value? What type of symptoms we have? We'll just say a couple of words about that. I know we have lots of other videos about that. That's kind of important because people are afraid of, too little or getting too low. Any pros about that?
Want me to take that one, Bo?
Sure.
So a low blood sugar is any blood sugar that's reading less than 4. And typically you feel shaky, sweaty. If you're sleeping, you'll wake up, particularly if you have type 2 diabetes. And so the reason that you are too low is because you have too much insulin in your body, whether your dose is too high or you were physically active, or you may not have eaten as many carbohydrates through the day as you typically would. Because if you have type 2 diabetes, you're on certain medications that need certain amount of carbohydrates throughout the day. Particularly something like glucoside. Don't use glyceride too much, but some people still are on that. So and I'll wait till we get into the glucose testing about some of the meters we have to be careful with, because you will feel the symptoms, particularly with type 2 diabetes. So anything below 4, regardless of how you're feeling, is a low blood sugar.
And to be clear, that's not the same as the one on the blood work. The blood sugar you're talking about, it's not the same. So if I do pricking my finger versus the one on my blood work, is that the same thing?
Same thing. If it reads below 4, it's a low blood sugar.
So if you the one they do at the lab, you won't know that because it's in the lab. The one that becomes irrelevant to you. You can go retrospectively and say what your blood sugar was. At one time, that's how we had to monitor blood sugar. We actually used urine dipsticks, and if you spelt too much urine, it got too high, or we didn't have finger pricks, so you had to actually go to the lab to measure it, and that way and you get the result a number of days later. So we come a long way about that, but it really it's a reflection of the same thing. Different ways of measuring it.
Yeah.
Sometimes not as precise as we want to, but it works pretty darn well most of the time.
Okay, and this is what I was referring to earlier. Some people do better with charts and numbers, and other people, I'm a visual person. So if we look at this graph, what it's telling us is the different types of insulin. If we're looking over a time frame, how hard is it working? So you can see that the Lispro, the first pink one, is going, the graph is going up really quickly and coming down really quickly. So that's the one that's going to match up with the carbohydrate intake. Remember, we said 1 to 2 hours of a peak. But it's not going to hang around for very long. It's only for 3.5 hours. Whereas the Tresiba with that lime green color, it's working for a long time, but it's not going to cover your meal because it's only working just a little bit. It's kind of like a little bit of a foundation of insulin so that the blood sugar never gets away on you. But there's different reasons that we take different types of insulin. If we want to cover a meal, we need something that's going to work quickly and for a short amount of time and not hang around for hours later. If we want to wake up with a good blood sugar, we need something that's going to be consistent overnight and have us wake up with a good blood sugar. So that's why there's different types of insulin. Okay, go ahead, Adam. Yeah, I was done. Oh yeah, and so then I guess this sort of reiterates my little demonstration that I did. There's directions that come with the pen, or your educator can talk to you. use a new needle tip each time you do your injection because they're made so fine. Prime prime the pen with a 2-unit air shot. The comment here, repeat until a drop appears. So what that refers to is, if, as I said earlier, if it's a new pen, you're depending on if you can see here, what's going to make the pen deliver the insulin is the plunger and the rubber stopper need to be lined up. So sometimes when you're opening your new pen, they're not lined up yet. So you might direct the pen to deliver 2 units of insulin and nothing even comes out. And that's not something that would be something to worry about. It's just the pen's brand new. You haven't lined up the plunger and the rubber stopper. And so you just keep repeating that until the drop appears. Once you've been using the pen, you won't need to do that. And then just a reminder that you do go in at a 90-degree angle, just like I showed you. You go in straight. And then once the dose is delivered, remember to count to 10, and then discard the needle in the sharps container. And I did make mention of the fact that the pen tip is very short. It's 4 millimeters. We used to think that, the different people need different lengths of pen tips, but now we've realized that really everyone, doesn't matter on the person. We just want it to go under the skin. And so the 4 millimeter going in straight seems to be the most consistent way to get the insulin into the right place, because we don't want it going in the muscle. And then Judy was talking too about site rotation and moving it around. This isn't the best picture, but basically the take home here is abdomen is the #1 place for injection, moving the injection area around. What I usually recommend actually is, if you can see on this diagram, that 2-inch circle around the belly button, there's a lot of nerve endings in there. So basically a person can be told to use their abdomen, avoid that 2 inches around the belly button, up and over as far as they can reach to one side. And then if they just move over by about 1 inch or the width of your thumbnail each time they do an injection, and then work their way back down and work their way back over. By the time they do that, they've given their body an opportunity to sort of recover from that insulin injection. They'll have a less tendency to have lumps or bumps or develop scar tissue. Sometimes people get in a real habit, there's muscle memory. And if they're right-handed, they always want to go to the left side of the abdomen, and they always want to go to the same place. And that will develop into some scar tissue potentially, and that's not a good thing, because then they might see Judy and I, and we might say, well, I don't know why your blood sugars are going up. And we might inadvertently think they need more insulin, where really they just need to be moving their injection site around. I don't know if you have anything to add to that, Judy.
No, just very, like I said before, very important to move it around. Men, and I'm not picking on men, are the worst. They go on either side of the belly button and think that they're rotating their sites. And those sites just become overused, regardless of the size of the needle. So really important to go side to side.
Well, if you just use the same site too many times, you're just going to develop scar tissue in that area.
Yeah.
So that's why you want to rotate sites.
Yeah.
Sure. And I guess I'll just sort of mention this to our audience listening. Bo and Judy are available at the clinic. I know a lot of this is for your information, for you to understand it, for you to sort of know what's going on. But sometimes you might need a refresher. Sometimes you might need to speak to someone. So really welcome you to sort of reach out, and for sure we could sort of connect you and sort of chat with you a little bit more.
Yeah, I think that's a good point, Adam. As you and I spoke earlier, sometimes people, even when they've been on insulin for a while, it's helpful to maybe get some feedback and see what's changed, what's new about the length of the needles, or what are we saying about injection sites and different things. And I know it's, again, I'm going to pick on the men too. For some reason, the men like to go in their legs, and they go close into the groin, like in the inner part of the thigh, where you can see on the picture, like there, again, there's a lot of nerve endings in that area. So it's best to go from the outer part of the thigh. So it's good to get a good refresher and touch base and see, sometimes we all get into these habits. We think we're doing the right thing and we just continue to do it, and it may not be the right thing.
Now, sometimes cost is a factor in using needles. What's your advice on about that?
Yeah, I mean, I guess, yeah, if it really is a factor, there's a few issues with the reuse, and part of it is the way that they're made. They really are made so fine. They really are designed for one-time use. The other issue is if someone's going to reuse the needles, it probably means they're leaving the needle on the pen. So there's a few things here. So one is, of course, the infection risk. The other thing is the cartridge in the pen is it's not really an airtight system because of the plunger. So if I leave my pen tip on there, that means that some air could get in there, some insulin could leak out, bacteria could get in there. So there's a few things that need to be considered. Um, I, yeah, I guess the person has to do what's comfortable with them. Sometimes what's a good idea is use that one pen tip for that particular day. So when you start your day, you put the pen tip on, you use that pen tip, and then when you put your pen away at night, you take the pen tip off. Um, yeah, and sometimes they can get samples. Um, and just if they are seniors, there is a grant from the Ontario government for people who are on insulin, syringes for seniors program. So they could access that too.
Thank you.
You're welcome.
Sure. So here we can talk about our patient, Dr. Curnew. Um, so this is our patient, our sample patient, who, I don't know, Dr. Curnew, do you want to give the history?
It's kind of interesting is that I one of the things is that I'm a cardiologist first, and then I became a lipidologist. If your triglyceride is greater than 2 at baseline, and you have a big tummy, you have insulin resistance, you're developing diabetes. 20 years, you can tell you're going to develop diabetes 20 years later. So I have something called familiar combined hyperlipidemia. So it gives me a high cholesterol and triglycerides. And like most human beings is that I'll lose the weight next time. My dad had diabetes. My brother, who's 2 years older, has pretty bad diabetes, and he's on insulin therapy. And I don't have diabetes yet. I have the genes for it. A lot of my family members have diabetes, so there's certainly a genetic factor. So what determines part of your success is luck. Number 2 is genes. 3 is hard work and watching what you're eating and exercising. So what happened to me is that when the pandemic started, I was always a little bit chubby, and I decided, well, when I heard that anything above the body mass index at 24 increases mortality for COVID and other infections, and we knew that from the start. But and so I made a point to really work hard at maintaining my weight. So I don't know if I'm going to get diabetes in my lifetime, but I'm certainly working hard not to get diabetes. And also remind people that in people who develop type 2 diabetes, people watch this hemoglobin A1C rise, and at 6.4%, people feel wonderful. At 6.5, they feel their life is falling apart. At hemoglobin A1C of 6.5% usually means that half the cells that make insulin, called beta cells, unfortunately have died, and the rest are working overtime. And so to me, this is a gradual process that happens many, many years. So I can predict diabetes by looking at triglycerides and how big your tummy is. I can look at the hemoglobin A1C as it tends to rise gradually, and you can do that too as well. But again, if the time you're made the diagnosis of type 2 diabetes, it's easy to control the blood sugar because you still have half the cells that are making insulin. But 10, 20 years later, you may have no cells producing insulin or very little, and that's when insulin becomes a requirement. So my plea to everybody is that a Canadian born today has a 50% lifetime risk of developing type 2 diabetes in their lifetime right now. I'll repeat that. If you're born today, the lifetime risk of you developing type 2 diabetes now in North America approaches 50%. And that's in part related to our weight and what we're choosing to eat. So please spend some time thinking of how important it is about that. So, is that I think that's the ICAT's Grey Cup. And so it's one thing to watch the Grey Cup. It's another thing to participate in the Grey Cup or just participate in any form of activity. I'm not sure if Judy or Bo has any words of wisdom about people's some lifestyle issues, or what you gonna say about my genes? Because I had the genes for diabetes, but the genes basically load the barrel. I pull the trigger by what I do about lifestyle changes and what I eat and what I exercise. And I can't control everything, but I can control some of that.
That's probably the most difficult that most of the patients struggle with is the lifestyle because, especially now we've just gone through a pandemic, people can't exercise to the level that they would previously enjoyed. They're bored and comfort themselves with food. And some of them have gotten COVID, and we don't have a lot of data yet, but a lot of people who contracted COVID were also tested and shown first signs of diabetes. So that's been a real struggle. But there's a lot of work. Medication is one thing, but the lifestyle is the other component of it. And some people would just like that one magic pill to make it all go away.
So the first magic pill is vitamin diet and vitamin exercise.
Yeah.
And really looking at that body composition. I can't stress that a lot. You talked about is that you can take less insulin by exercising, and you can protect your pancreas better by exercising well. I know it's not easy, but you know what? To say that 50% of Canadians will have diabetes in their lifetime, it's frightening. And it doesn't have to happen. Yes, it requires a colossal change. So I know right now the governments are talking about, global warming, and one way to help global warming is to basically use your car less, get on your bike, do something. And you mentioned COVID. I'm not sure if you know this right now, but is that people who have COVID and then in the year afterwards, a 40% increase in type 2 diabetes. COVID damages beta cells, and it accelerates diabetes. And it's probably not the only infection that does that too as well. No infection is good for us, and COVID seems to be particularly bad for the pancreas. Well, what do you tell the people? Say, I know you want to meet people where they're at, but don't stay where you are. Go, don't look behind you. Just move forwards. And how do we? This is so important. This aspect of things, and how much you weigh determines whether or not how are you going to get diabetes or not for many of us. I know but you know what? I enjoy exercise. I'm the guy who can finish last in a marathon. Everybody's gone home. The guy at the thing says you're disqualified because you're too late. And but you know what? It's good. I'm happy most of the time. There's always next year to get better, but at least you're out there and participating and having some fun. Don't forget, Adam, we're going to do the stairs in about a half an hour after we finish. I got a couple more things to do first. And anybody can just, we're going to the Shadok stairs a half an hour after this session's there, and we're going to improve our pancreatic function tonight. Come join us. Bo, what's your thoughts about people? When you say this?
I know. I mean, the first thing that people need is to be heard. So we need to find out, what's happening with them, what's causing them stress, what are they currently doing. But the other thing, sometimes people can really get down on themselves and it seems like a huge mountain to climb, excuse the pun, but everyone's just got to start somewhere, and most people can walk. I'm sure as a cardiologist, you know, even when people have heart problems, you're wanting them to move and walk. So most people have a good pair of shoes and they can walk. I think it's important to just do some realistic goal setting. And as you said, you're not going to run a marathon, but any more that you do this week than what you did last week is an increase in your activity, and you just have to keep doing more, increasing your activity level. Because we also have to think too, where everyone's getting older, and it's not just about diabetes or weight. It's also about what's your flexibility, what's your strength, and even your risk of dementia and all those types of things as we age with atherosclerosis. And activity is very, very important for us.
Sure. So here we're going to just discuss quickly the finger pricking just for a second. You know, this is some of the common questions we get. So in terms of how does it work? So sometimes, you know, we discussed this before the recording, but, you know, we're going to bring it up again for folks. But can I just buy it from the store, the strips for the glucometer, or do I need a prescription for it? How does it work?
So you could, Adam, you could just go in and buy it at the pharmacy. But most people have some kind of a coverage that requires a prescription. And so a prescription, going to the pharmacy, and you would get a kit that would include the meter and the equipment required to poke the finger to get the blood sample. And then you get the strips separate, and they're about the strips are about $1 a piece. Most often you can get the kit for free because you need to purchase the strips. If you purchase 100 strips, you get the kit for free most often in most pharmacies.
Never ever buy a glucometer. They just buy the strips. Absolutely. So if someone wants to sell you a glucometer, go somewhere else. And also, you actually don't even need a prescription for insulin.
That's right.
You don't.
Is that, you know, so and so for people who have a drug plan, you want to get a prescription so you can get your drug plan to pay for it. But if you're paying for out of pocket, you don't need a prescription.
And then you save the
Yo,
dispensing fee.
Did
Yeah. And then some of these we already discussed, so maybe you could just sort of skim through them. So can I exercise on insulin? Yes, we can. We just sort of have to time it right and sort of, you know, in fact, exercise is is encouraged when you're on insulin. So there's that. What are some of the weight loss challenges you find with people on, you know, on insulin? I'm not sure if you have any thoughts on that.
Well, there's a couple of things. Again, if they're not if they haven't got the tools to do the exercise after the meal and reduce that mealtime insulin, then they might have low blood sugars, and then they're fearful of that. The other challenge around losing weight, if they don't cut back on their insulin, they might get frustrated because they're not successful with weight loss. And if they end up having too many low blood sugars, the treatment for a low blood sugar is oral carbohydrate. And so they might actually be taking in more calories related to the exercise that they're doing if they're on insulin. But really, again, if we start them off on a basal insulin, they should be able to exercise. And yeah. I don't know if you got anything else to add to that, Judy.
Traditionally, we start someone on basal insulin 10 units at nighttime. How do you like to titrate it? We're taught to increase the insulin by about 2 units every few days or so.
Yeah.
And one rule of thumb: if you're on insulin, you need to monitor your blood sugar to do this properly. The 2 agents that lead to low blood sugars are insulin by far and something called sulfonylureas. And what the sulfonylurea has the least amount of hypoglycemia, something called dimicron. And these agents actually are associated with some weight gain, about 5 to 10 pounds, or makes it harder for many people. Insulin makes you hungry. And same thing with sulfonylureas. So some agents actually promote weight reduction, and some are weight neutral. It's not a huge amount of weight. It's a little bit of weight, but every pound adds up to that equation there. So, and if you think you're having a reaction to insulin or to your blood sugar, measure your blood sugar. I see so many people think they know what's going on, and you have to measure it. If you think you have a low blood pressure, you measure blood pressure. You think you have a low blood sugar or high, you have to measure it. So you got to be detective work over here. That first slide was a detective slide. So don't be your own detective. Rate of change in blood sugar is important, and actually the absolute number or two are both important too as well. And we know that is that the higher your blood sugar, the more eye damage you get, the more kidney damage you get, and the more nerve damage you get, and get something called neuropathy. So that's important. There's a different sets of criteria for heart disease. So, and so to me, for most of us, if you're sick, not feeling well, you need to do extra adjustments and measure things. If you're going out to celebrate, you'll need more insulin. If you're, depending on type of diabetic you are. Well, for most type 2 diabetics, it's not a big change. It's pretty stable most of the time, I find. Any pros about how to titrate blood sugar from Judy or Bo? How do you like to do it?
Usually every 2 to 3 days, and of course monitoring it. And typically for the insulin, because it's just for most of them, it's one dose. We look at the fasting blood sugar and go up about 2 or 3 units every night or every second night until they reach their target, which is usually between 5 and 7, depending on their situation. The only insulin that we don't do that with is the insulin called Tresiba, because it has a longer action, and we do that usually about once a week is probably the easiest way to manage that. But the other ones are usually every 2 to 3 nights based on the fasting sugar.
So let's, for instance, you wake up at, like I wake up at nighttime because I have to go to the bathroom. So that's not low blood sugar. But if you're getting a headache, you're feeling unwell, you think your blood sugar is low at nighttime, then measure it. If you're seeing I'm having these bad vivid dreams and think I feel shaky, measure it. And find out where you stand right now. Then report back to somebody who knows a lot about these sorts of things. It's important. You can't manage what you don't measure. Let's hear about measurements, medication. Tell us more.
Or yeah, so we were talking about costs a little bit. So maybe I could just open up the floor here to give us some ideas. So this is per daily cost, so daily treatment cost. So you have stuff like metformin, which is really cheap per day. I think Crestor is in the same category. It's very cheap per day. We have things like glycolazide, which we were just talking about, sulfonylureas, and pH insulin, and then you just sort of move up a little bit. And then there's Jardiance here. So you can see it's really getting expensive, but when we get to the Ozempic as well, it's around the $4 a day. That could be changed depending on, this is assuming it's a 4 milligram pen and you're on 0.5 milligrams. So that's assuming around 8 weeks of usage. But if we were to sort of take 0.25, then that can change the equation a little bit. So that's something we could discuss, Ozempic, but I'm not sure if you guys have any thoughts about the chart here that we'd like to discuss in a bit more detail. Good.
I think it's important to decide, what you need and what you can afford and how we can help supply that. So I have boxes of samples for some people, and I know there's different programs available. Maybe Bo and Julie can talk about what programs are out there to help people treat their diabetes and some of the costs available. And don't be afraid to discuss costs.
Well, there's not a lot of programs. So there's government programs. there's Diabetes Canada has monitoring for health to help pay for the cost of the strips. And there's some compassionate programs with some of the pharmaceutical companies. Otherwise than that, you know, there's not a lot of programs.
Okay.
Yeah, it's a difficult thing. It's actually, you know, sort of an ethical dilemma, Dr. Curnew, because there's all this research being done, developing all these medications, and then, you know, unless people have coverage, it's hard for them to access these medications.
So for those that are our seniors, we have all forms of insulin available, and I think one of the things is like there's ways of as Adam was telling you about, we can make something like Ozempic a quarter of the cost for some people by the type of pen that you use. There's two pens for the same price, so you can, you know, you get twice as much in one pen, for instance, and what is a good best dose for you as well. So lots of things to think about. For SGLT receptor antagonist, I can just half the pill and I make the pill in half, for instance. I can do that. You can see that's why sulfonylureas are been around a long time, and metformin has been around for a long time, so relatively very inexpensive. And both these drugs have a great role, and they're very useful. We always want what's always new. New is not always better, and we can talk about when it is better for you. So please discuss cost.
And another option might be to send the patient to an education center, like where Bo and I work out of, because we have access to more samples than, say, a GP. Some GPs are very fortunate and can give help samples, but if they're really struggling and omitting their medication because of the cost, that might be an option.
Thank you.
Awesome. Okay, so this is kind of, we're touching towards the end, so we can talk a little bit about Dexcom and Freestyle Libre. So Dexcom is a little bit more sensitive to changes, and it sort of alerts you when there's sudden, you know, spikes and going down. So it's really helpful for type 1 diabetics. Coverage is, as of now, and you guys can correct me if I'm wrong, but it seems like it's only third-party coverage as of now. So insurance companies, you sort of changes every 10 days. And yeah, so it alerts you when there's highs and lows, as opposed to the Freestyle Libre, which is, you can use it for both type 1 or type 2 diabetics, but it's kind of a good alternative for, you know, not having to prick your finger each time. It's if you're a little bit more stable. And so for that one, you'll need to prick your finger if your blood sugar goes below 4. Just to confirm, you know, the double check and making sure things are good there. In terms of coverage, so Bo was mentioning it was for if you're on insulin, correct? And is there an age requirement?
So in Ontario, if you're on insulin therapy and you're a senior, the Libre is covered by the government. It's $90 every 2 weeks, I believe, for these little discs. The Dexcom I don't know too much about. And what I like about the Libre system is that it's fun. You can actually do things. And you can understand your blood sugars. And keep telling us. Go ahead. Tell us about this. Go ahead.
Yeah, no, I just want to bring the slide as you were talking about it, so people have a visual. So this is what the sensors look like. It's kind of, you know, just sort of put a patch. I believe you could take a shower with it, right? It's waterproof.
Oh, absolutely.
Yeah, there we go. Okay.
Yeah, and you can go swimming.
Yep.
And just to go back to the Dexcom for a quick second, so just within the last couple of weeks, the Ontario government will pay for type 1s to receive a Dexcom if they meet the criteria. But the criteria is pretty severe. They have to have had a severe low blood sugar, EMS, took to the emergency department, lost their license. So it's pretty severe. They've really restricted who can have access through this government program for the Dexcom, which is the picture on the lower right. And also they can use their phone. So those are showing the readers for both. But both the Libre and the Dexcom, you can put an app on your phone and do the scanning that way too, which is most helpful.
So the glucometers, those strips, they're $1 a strip. So depending on how often you're checking your blood sugar. Now I always forget this is in Ontario. How many strips are you allowed for blood sugars, monitoring with or without insulin therapy again, Bo and Judy?
If you're on insulin therapy, I believe you get $4,000 a year. If you're only on pills, they'll give you, I forget the actual number, but it's less than testing once a day. So it's very limited.
And if you're just taking oral, if you're not taking any medications, will the government pay for strips at all or not?
I don't believe that they will.
Okay.
If you've got third party, they will, but the government won't. ODB won't cover it, I don't believe.
And so it's remarkable how this technology has changed and it can make a difference. Now, one of the things is that people go driving, and before you go driving, what type of blood sugar should people have before they drive their car?
5 to drive.
5 to drive. Okay.
That's great. Easy to remember.
Very easy to remember. So it's not a low blood sugar, but if it's below 5, you need to have something to eat. The ministry would like you to wait 45 minutes before you drive. But yeah, and if you feel that your blood sugar is dropping while you are driving, you need to pull over to the side of the road as soon as it's safe. And if you have a key in the ignition, to pull that out. It's not just enough to turn the car off. You take the key out of the ignition, and that indicates that you had no intention to drive. So you can lose your license if you're pulled over and found to have a blood sugar below 5.
And one thing to remember, if you ever have a suspended license, don't drive. Your license has been usually suspended for a reason. If you want to argue that effect, fine. It's a terrible offense to drive with a suspended license. It's a terrible offense to drive if it's unsafe to drive. I've known people that unfortunately have killed other people because they didn't listen to good advice. So no one takes pleasure about having a license and suspending. In Ontario, it is a law that if any healthcare provider feels a person is unsafe to drive for any reason, they must notify the motor vehicle department. There are certainly ways of getting your license back and things of that nature, but you have to make sure driving is a privilege, not a right. So it doesn't happen too often, but these are things that are important. So I think, monitoring is always a good thing. I didn't know about taking the key out of the ignition. That's important to realize that shows intent. Thank you. Any other thoughts about these devices? Are life-saving, wonderful things. For some people, it's more of a luxury. For some people, it's a necessity. And so you have to decide what you want to do. For instance, I use the Libre device on and off from time to time. I have fun with it, and to me, it's a pleasure to help me gauge what I'm eating, how much I'm exercising, what to do about it. For many people, it's life-saving, and so you can decide what your healthcare provider, what system works best for you, and at what cost.
Sure. And I'd just like to point listeners as well to the multiple videos that we have about diabetes. So one of them is the different types of blood sugar and how to interpret your lab values. So that one is a really interesting video that I really recommend you check out, and talks about the glucose random versus the HbA1c and all that technicality stuff. And hopefully it'll make things a little bit more clear. Nermi, I don't know if you want to talk a little quickly about the diabetes intermission.
For sure, yeah. So when we're looking at the slide, I know there's a lot of content here, but what we kind of just want to focus on specifically is the idea that you can't really cure your diabetes for type 1 or 2 diabetes, but you can put, especially type 2 diabetes into remission. And so we usually haven't heard of this word remission in the context of diabetes before, but the more technical way to explain it is the tests that you get at the labs, the HbA1c test specifically, if you can get that value lower than 6.5% after withdrawal of those anti-diabetic drugs at a baseline. And so what that means is being able to achieve that HbA1c value less than 6.5 whilst, not taking any of those diabetic drugs. Now, right now, we don't really have a cure, for diabetes, but what we've realized is one way to help put your diabetes into remission is to lose some weight. And the main trial that kind of looks at this is known as the DIRECT trial from the UK, where they got some individuals to just take normal therapy, and then other individuals, they gave them this really strict diet and helped them support long-term weight loss. And what they found is in the group that had the really strict diet to lose that weight, individuals ended up having a significant drop in their HbA1c values. It saved a lot more money for the government. And also, a lot of individuals didn't need to take their medications anymore because they just, they were either in remission or it was not necessary anymore. And so what can we take away from that study and what can we apply in our context here? It's pretty simple. We want to work our best. We want to try our best to lose that weight if possible. And one way we could do that here at the clinic, we do have our sugar hours club, and we also have our weight loss club. And an initiative that we're running right now is the 30 pounds in 30 weeks. So we're all trying to lose 30 pounds in 30 weeks, and we'd love for you to join us. If that's something that you're interested in, just bring it up in your next appointment and your next visit, or give us a call at the clinic, and we'll try our best to figure out how we can best support you.
Thank you, Nirmay. And yeah, this is, I think, a big thing we'd like to emphasize. We want to work with you to achieve this. It's doable. It's going to take a lot of work, but nothing happens without a good team. So we really have to create an ensemble. It takes some time, but we'll sort of get there. And with that, where do I go from here? So we'll sort of finish off with a little bit of an action plan, talking about where to go from here, how to put this into context. So yeah, just start with realistic expectations on where you want to go. Slowly start replacing unhealthy foods with healthy ones at home. And on the go. If you're going to go through drive-through, maybe don't get that chocolate chip muffin. Maybe get that every other week. Plan out your meals. That's actually a big thing that I kind of notice. Sometimes I kind of go to the kitchen and I don't plan what I want to eat, so I kind of just eat whatever is available, and that tends to be chocolate. So if you have actually something planned there, something fruits, maybe if you when you get the groceries, you cut the fruits. Now that's kind of what we do with my family, just sort of cut the fruits, put them in the fridge. So that's the first thing you see, and there we go. So you kind of have that there. And don't the all or nothing approach. We're gonna have some failures, we're gonna have successes. It's a very curvy road. And track and monitor things. We were talking about blood sugar, but also blood pressure. It's one of those things that you might not feel it, but it's important that we keep measuring it. We keep a diary. So whenever you come to your appointments, it's a little bit more of an informed discussion from your perspective and from the physician's perspective. And yeah, so I guess we'll finish off here with Diabetes Canada, which is a great resource. Just diabetes.ca. There you'll find multiple recipes. I think there's a lot of recipes. So even on our YouTube channel, our cooking club, which meets on Sundays, but also we have Diabetes Canada, which would be really helpful. So you could filter by gluten-free. So we'll put that as well in the description box. So you could sort of reach that, but gluten-free, vegetarian, vegan, dairy-free, and the list just sort of goes on. So, if you ever feel stuck, just feel free to check out Diabetes Canada. And with that, I believe we have reached the end.
Well, truly wonderful. I want to thank everybody for participating. First, a special thanks to Bo and Judy, who joined our clinic and added years of experience to them and made us all better at understanding diabetes. I want to thank Nirmay and Adam, who spearhead trying to prevent diabetes or put your diabetes into remission. A special thanks goes to Stuart, who somehow keeps us on track and going, and who's really instrumental putting these together. This is a work of so many people, and I feel very grateful. I'm very grateful to all our patients and all our participants. And I just want to say thank you. And so basically, insulin is not a 4-letter word. It's a tremendously useful product for the right time and place, and there's many insulins available. And at one time, I was afraid of insulin. Now I'm less afraid of insulin, and I learned a lot more tonight. Any words or thoughts from Bo or Julie that you want to add today? Because I just want to say thank you for looking after so many patients in so many places over the years, and thank you for this wonderful insights today. Thank you.
Yeah, Dr. Curnew, I think Bo and Judy had to head out.
Okay.
Yeah, but obviously, they're thankful they were here, and again, we really thank them for joining us. They've added really a lot to the webinar, and we were able to have a informed back and forth.
And
So yeah.
And they actually, they're here at the clinic as well. So if you're privileged to spend some time with them, make sure you use that time wisely. Don't miss it. And don't miss anything anymore. There's not enough of anything. Stuart, what's your thoughts?
Well, I do have some questions, actually. I'm curious to see if I can get your perspective on them. One more from a perspective of yourself, Dr. Curnew, and then the other from maybe a patient perspective. But for the first question for you, more from a healthcare provider's perspective, but we often hear about diabetes medications and we hear about insulin. Just curious to know the difference between the two of them. Like, my understanding, it's always been that diabetes pills, they don't work for type 1 diabetics who don't produce any sort of insulin whatsoever. It only needs to work for people who have some sort of functioning pancreas, for specifically type 2 diabetic patients. Is that the case? And how do you decide when a person should be on one, the other, or both?
Yeah. So type 1 diabetes, as you're right, is a problem where you don't have insulin production. And basically, the only solution is insulin to that for medication wise. Type 2 diabetes is a problem of it's relative. You don't have enough insulin for what your body needs. Now, most of us secrete about 40 to 50 units of insulin a day. In a type 2 diabetic, you can be secreting 80 units a day and still not being enough, because what happens is your body becomes more resistant to its own insulin. The insulin doesn't drive the sugars into the cell in the same way as a healthy person. And the key to that for many people is make your body more sensitive to insulin, and that's diet and exercise and losing weight. Losing weight is a crucial factor in this. And if you see, as for instance, and type 1 diabetes is more a disease of younger people, type 2 is more as time goes on. Obviously, there's a degree of overlap, but it's not entirely true totally. So these new drugs, things like sulfonylureas, what they do is they make the body it pushes your body to use more, to make more insulin, to use insulin better. SGLT2 receptor antagonists cause you to pee out sugar out of your kidney. It lowers blood sugar through that mechanism. And so to me is that you need to have baseline insulin that you can make work better. And that's what most of the oral agents do, where insulin just is replacement. So if you happen to be an older type 2 diabetic and you're very skinny, that probably means that your body's not making insulin anymore because you don't have much resistance. So in that circumstance, you'll have to go to insulin earlier. And if you're sick, you'll need you need this extra insulin. So many people who are hospitalized may need insulin for a period of time and may not require it long term. So and the decisions of what combinations of medications to use is very much a decision that you have to make with your clinicians. So recently, the most two important categories of medications I think are glucagon agonists like Ozempic, which is very important for weight reduction. That's one reason why I use it. But it also decreases cardiovascular events by about 15%. Where the SGLT2 receptor antagonists are used to protect the kidneys against end-stage renal disease, decrease end-stage renal disease by 40%, and they protect against congestive heart failure, decrease hospitalization by about 30%. And these drugs benefit are independent of the blood sugar. So it's not just the blood sugar that's important, and they work outside diabetes as well. So it's a complicated answer, and that's what you need your clinicians to do and your diabetic educators. But and that's because they know as a practicing cardiologist, it would be a big mistake if I didn't use these medications because they do affect the cardiovascular system and integrating that. And cardiologists now are entering this field to look at that. Traditionally, it was the job of family doctors, endocrinologists, kidney specialists, but now it's the job of everybody. And it's also your job to understand your diabetes or potential for diabetes and how to work with your healthcare team. There's so much you can do. The frustrating part is that I wish more people would learn more and work with us so we can help you be a healthier you. And that's the point of all this.
So speaking of being healthier and putting diabetes into remission, say I'm someone who has diabetes and I'm really motivated to lose some weight through diet and lifestyle changes. Should I speak with my cardiologist, my diabetes specialist about adjusting my insulin before I undergo such a process? Or is this something that should happen once I start trying to make some lifestyle changes?
It depends what stage you're at. So if you're a brittle diabetic prone to hypoglycemia, you'll need some expert help. But probably the most important person you need to speak to about your journey in diabetes prevention is your friends and your significant other, how to lose weight and how to get a team approach about that. So so to me, that's probably the most important group of people is your family and to do this team approach. And then certainly, obviously, if need be, and to adjust things, yeah, you need to speak. If you're taking medications for diabetes, you'll need to speak to the right people. Now, certain medications so glucagon agonists and SGLT receptor antagonists work independently of blood sugar. So really, the probability of hypoglycemia of these agents are very, very little. Where if you're taking insulin or sulfonylureas, the probability of hypoglycemia are much greater. And remember, to prevent heart disease, stroke, it's not just the blood sugar, it's the blood pressure, it's the blood cholesterol, and the quality relationships you have are so important.
Great. Well, thank you, Dr. Curnew. I wanted to thank Booty and Bo and Judy as well for taking some time this Friday evening to answer some of our common questions that we have. And I want to thank Adam and Hermy for putting together such a great webinar and a great program for helping support people who are working to put their diabetes into remission. Dr. Curnew, did you have any final words before we go off tonight?
Yeah, for some of us, not gaining weight is a big thing, and so we're talking about losing weight, but not gaining weight is actually a big plus for many of us. And special thanks to Adam and Hermy because usually the first Saturday of every month at 9 o'clock, we spend an hour different topics. So we're having one again tomorrow, and all these things are recorded. So please take a look at them. And then we have many people from the past. Judy and her team put together some wonderful videos on diabetes. So please go to our YouTube channel, take a look at them, put diabetes, and you'll find out 15 different selections on diabetes. How to help you, how to help with that. It takes time to learn, and thank you all so much. And I want to bid everybody good night.
All right.
Thanks so much, everybody.
Take care, everyone.